Okay, so we are going to talk for the next 20 minutes about the different cases where we can use perfusion in tumor imaging and what input can we have. So tumor imaging is something quite difficult. So first of all, there is the initial tumor management that can be challenging. First of all, we need to know when we find a brain lesion whether it's a tumor or not. Then we need to characterize it, to grade, and when we want to do the biopsy, we should know where to go, or should we do directly the resection. So all these questions we should answer as a neuroradiologist. Then, once the patient is treated, usually has surgery, radiotherapy, chemotherapy, and then he is followed up, usually quite closely. And on some point, we will have a contrast enhancement that will appear, and we actually have to know whether it is radionecrosis or some post-treatment abnormalities, and then we should just keep the same treatment and follow up, or it's progression, and we have to change the treatment. So there are sometimes it's a real progression and we think it's progression because there is a contrast enhancement and then we are right. Or there is a real response because the contrast enhancement is reducing and then we're also right. But there are a lot of cases where we, in our first impression, just based on morphological imaging, we can make a mistake and then we will change the treatment of the patient when we shouldn't change it or will not give the appropriate one. And because the timing is very short, we should do the appropriate decision as fast as possible. So usually we follow up the patient quite closely, but there is no real gold standard, neither on the timing of the follow-up, nor really on the multimodal MRI that we should do. Usually we do, of course, always flare, contrast enhancement, diffusion to see if there is any restriction that can show us hypercellularity, and of course the perfusion. So why do we do the perfusion? So there were different perfusion models that were suggested for many years. So the most classical one that is used is the DC perfusion that is showing the increase of cerebral blood volume inside the lesion. So when the volume is actually increased comparatively to the control region, we would assume that it is a progression. And when there is decrease of the volume, or if we see any leakage, we will assume that it is probably a response. So this is a general case, and there are some studies that have shown that the sensibility specificity is not that bad, but it's not perfect. And also the main problem is also the threshold that is extremely variable. When we see on the studies, the threshold varies from 0.9 to 2.15. So actually it's huge and it's extremely difficult to make a diagnosis on the individual case, even if in a series it could eventually work. There are also other problems that we can experience, like some patients that are treated by an anti-angiogenic therapy, where we will have some pseudo-response, where we will see that perfusion is normalizing when actually it is not. And also we can experience a lot of artifacts because there are bleeding, because of the surgery, because of radiochemotherapy. And then we will actually not see on our map whether there is a hyperperfusion or not. Also, the problem is the prognosis, that sometimes we will see a lesion on time t that is somehow hyperperfused, but would it mean that actually it will progress, or does it mean that there is some neoangiogenesis but it is stable? So this is something we also need to know. So additionally to DC, there was also ISL perfusion that was proposed. So this is something that we will use we do without the contrast enhancement. So we will mark the spins, and then we will see calculate the difference between the marked and unmarked spins to deduce the cerebral blood flow. So there are some limits of the sequence, as it was already discussed before. In the classical sequence that we have as product now, mostly we have only the cerebral blood flow. So we don't have the several markers that can be helpful. And also, even if diagnostic performance can be sometimes better, and it's also less sensitive to artifacts, and we can see in the case here that we saw previously where we could not answer, here we clearly see that there is hyperperfusion. Still, the sensibility and specificity across the studies remain variable. So sometimes we need something more. So there was some PET markers that were proposed. The most common PET markers is FDG. The problem of FDG for the brain tumor is that there is a real strong brain physiological FDG binding, and the glucose metabolism can be variable, and it depends on a lot of factors. So when there is an infection and inflammation, we can have hyperperfusion. So finally, for glial tumor diagnosis, the sensibility and specificity are really limited. There are some tumors for which it's interesting, like lymphomas, where we have really a strong FDG uptake. So then amino acid traces were proposed, such as DOPA or FET, that are much more sensitive and specific. So we would actually compare the lesion comparatively to striatum, and we consider if the lesion uptake is higher than the one of the striatum, then it's positive and the lesion is probably progressive. The problem is that it's still not always the absolute response. The sensibility and specificity are yet variable, and also that availability is limited. Like in our center, every week we would see a multidisciplinary meeting, 40, 50 cases, and we have 4 PET MR slots with DOPA the week after. So we have actually to pre-select the patients that we will send there. We cannot send them all. Also, there is it is still debated how the PET and perfusion images coincide. Is it redundant information or is it complementary information? So we have done this study where we have seen that actually it doesn't coincide completely. So we have some regions that have more neoangiogenitis, while the other regions are more hypermetabolic. The limit is comparatively to what we can do now, and this is something that we aim to do with the multiple markers. Here we used ISL only because comparatively to ISL in our cohort, actually the classical RCBV as provided by the vendor was underperforming comparatively to ISL. But now this is something that we want to reanalyze with the new markers. So in this context, we are really interested to test the new markers to see what can it bring to us. So the Sarkar proposed these markers. I will not detail them because we have already spoken a lot about them, but the main ones that we would look in the brain tumor imaging is the CTH. So we want to look what is the change in the capillary morphology actually related to the tumor-related induced modification, the oxygen extract function, and also the cerebral metabolic rate of oxygen. So I will show you these different markers and how we think we can use them on the basis of some examples. So first of all, on the first assessment. So here we have a male, quite young, with headache, and we have this tumor. Okay, so we're quite sure that it's a tumor. The problem is that it's a huge tumor. We cannot resect it. So we have to do the biopsy. The question is where to do the biopsy because the lesion is big. So we will, there is no contrast enhancement. So we should really base ourselves on perfusion imaging. So here we have the RCBV and the CMRO2 with quite large suspected volume, but also there is one part that have increased CTH. So eventually we thought, okay, to look where we should do the biopsy, probably we should do it in the place where all the markers coincide, so probably it's the most aggressive part of the lesion. So this is something that can be helpful, and we should more analyze it more, but we think that really it can be helpful to choose where to do this biopsy. Then we can go from the first assessment to the follow-up. So this is the first assessment of this glial lesion that was actually glioblastomas, quite aggressive lesion. You see that all the markers are increased, but it was relatively limited, so we could go directly to the resection. So say, okay, it's quite limited, there are no suspected markers outside, so we can do the resection. But then, of course, we know that when we do the resection, we have to closely follow up because we cannot do the complete resection, and eventually there would be a recurrence. So we followed up this patient. And indeed, we saw this contrast enhancement that appeared sometimes after the radiation chemotherapy. And we have looked if there is any hyperperfusion. And especially on these subcortical lesions, it's very difficult on the classical CBV maps to see if there is eventually hyperperfusion because there are a lot of vessels and we don't know what to think about it. But when we look at SEMERO2 map, then we see that there is a real increased SEMERO2 values in this region that are much higher than all around the cortex. So it was a retrospective case, so we didn't have this map on this moment, and we just followed the patient because we have only the classical CBV map, and we considered that actually there was no hyperperfusion. And 2 months later, the patient was, there was an edema that was increasing, and the patient underwent PET-MR. And here we can see that there is, in this region, where we already had 2 months before the SEMERO2 increase, now there is a high PET doppler binding, and also the OF is increased. So actually it was a progression, and finally, if we would look at the maps in the very beginning, we would be able to tell that there was a progression 2 months earlier, and it's very important for this patient because we can treat them faster. Also, it can be interesting when we are doing early post-operative follow-up, so like this oligodendroglioma. So the patient had the surgery and the radiation chemotherapy like usual, and so there was this early follow-up. And actually, when we look at the perfusion, we don't see much changes. But here, when we look on CTH map, we see that there is something wrong in this region, in this very early post-operative MRI. And finally, patient, this was also a retrospective case. If not, we would do something about it. But patient was followed, it was a long time ago, patient was followed up for a while. And 3 years later, so it took time, but you see how early can be this suspected biomarkers, how early it can appear. So 3 years later, actually, we saw that there is an hyperperfusion that appeared in this site. And it was confirmed by Doppler. So here we see that there is a high increase Doppler binding, so there is no doubt that now there is a recurrence here. And you can also see that FDG is not the best marker here, because in FDG we don't see any increased glucose metabolism, while there is a real tumor recurrence. In this case, we were also wondering if there was a progression or radionecrosis. So actually, this patient was treated by Avastin, and we see here that there is some bleeding that appeared in high T1 signal. But additionally to the bleeding, we see that there is still a contrast enhancement. So we wanted to know if this contrast enhancement was actually related to the tumor progression or not. When we look at the basic RCBV, we see that this contrast enhancement coincides with some hyperperfusion. So we can actually suspect that there is still some active tumor. But this is extremely important. We have always, as we discussed before, correct our RCBV for leakage, especially in these cases in multi-treated patients where we have a lot of vascular alterations and a lot of leakage, and when we correct for the leakage, actually the RCBV is normal, and this was really a radionecrosis, and the patient underwent PET-MR, and we see that there is no Doppler binding. So we have a perfect correlation. Another complicated case. So here it's a man, 43 years old, with astrocytoma, radiation chemotherapy, with this big contrast enhancement that appears. And actually here we have our ISL imaging. We see that there is a hyperperfusion here, the quite proximal one, but there is also all this superficial hyperperfusion. And when we look on our maps, we can see, so this is the same time point, just 2 different levels. We can see that there is actually central hyperperfusion also with OF increase. But in the periphery, it remains quite negative. And when we look on our PET imaging, we see that it's quite concede here because there is a central increased dopa binding, but in the periphery it's not higher than the one of the striatum. So finally, what happened in this patient? He underwent electroencephalogram, and there was a post-treatment seizure that was infraclinical. So all this peripheral hyperperfusion was related only to this, but helping to the advanced marker, we could actually differentiate from what was the real tumor and what was the post-therapeutic and seizure-related hyperperfusion that we saw actually in ISL, and it perfectly coincides with the data that we saw on PET. Also, it can be helpful in the case where we have several lesions, where we are wondering if it's progression or adrenocrosis. So here we have this contrast enhancement. So first of all, it's already interesting because here on RCBV, we don't see any perfusion. But when we look on CTH and OF, there is actually one associated with PET, increased PET binding. Actually, even in CTH and OF, it's easier to tell than on PET. So we concluded the progression, and it was actually a progression. It was confirmed. But what was mostly interesting that there was this second lesion that was considered to be rhabdomyosarcosis because it was there was a few contrast enhancement. It was very cystic. But still there was some PET dopa increased uptake here. And the perfusion profile, this is why it's interesting. We had this discussion yesterday whether we need to choose one map and look only to it or if we need multiple maps. And I think that for complicated cases we need multiple maps because here looking to multiple maps, we can see that actually the profile is exactly the same. And obviously it was also the second progressive lesion. We can also help into this predict the evolution of the lesion. So here we have this contrast enhancement. The hyperperfusion is really low, but we still have the corrected hyperperfusivity that is increased, and also the curve that is increased in this lesion. And when we follow up this lesion a little bit. So this was just 1 month. And here on PET, we have this strong uptake. And just 1 month later, we see that there is a strong increase of contrast enhancement. And so if we compare what we see on PET dopa and what we see on the perfusion maps, actually it's quite coincides. So both of them, whether we use dopa or whether we use the perfusion maps, can help us to predict that the lesion will increase. More than sometimes we have also some lesions that we know that it's a tumor lesion, like here in this flare. Okay, there is really something that is tisular. But we want to know if actually it is a progressive lesion or not. And when it's close to ventricles, this is the second difficulty. We saw that when it's close to cortex, it's difficult. When it's close to ventricles, it's also difficult. So here we can see that there is some asymmetrical increase of CTH, but we think, okay, whether it exists or not, because it's close to ventricles. But actually, indeed, it exists. Even if sometimes we are wondering, that's why we look on several maps. So we see the hyperperfusion, CTH increase, and actually, when we follow up this patient, there was really something that appears exactly in this place. On the other hand, here we have another lesion. So this lesion was look really aggressive because there is a contrast enhancement, there is hyperperfusion on RCBV, but when we look on CTH and OF, it's really negative. So it's a little surprising. And we follow up this patient really closely, and finally the lesion was not progressing at all. It was even regressing. And in this case, the CTH and OF overperformed comparatively to PET, because in PET there was quite a high binding and actually decreased without any treatment change. We can use these methods for glial tumors, and we're already saying. But also the other problem that can be interesting and where we need some help, it's also the secondary lesions. So here we had this patient with probable glioblastoma. But when we look on this lesion, it's very limited. And also what is very interesting, that when we took all our maps, and here again we can see that when we take all the maps, it can be more interesting if we consider just one map. We see that the lesion completely coincides, while the glial lesion usually it's quite heterogeneous, and we would expect that different markers will show different profiles. And finally, it was well limited, everything considered, and indeed, this lesion was a lung cancer metastasis. So I think this is something we're also planning to more work on it, is the metastatic lesions, because the follow-up of metastatic lesions is quite complicated. So now we have a cohort on these lesions where we are doing a perfusion, ASL, and then the patients are followed up, and some of them have the biopsy. And it will be really interesting to analyze it to see if and which biomarkers can be really helpful to us to distinguish between the radionecrosis and progression that can be even more challenging in metastatic lesions than in the glial lesions. Finally, another case where we can use the perfusion, of course, is this kind of tumors. So this is the primary brain tumor assessment, and here we see this large enhancement with the diffusion increase, so we can already think about what kind of tumor it can be. But when we look on the perfusion, we can see here, if we look only on the values without leakage correction, we can see that the values are quite surprising, and when we look do the leakage correction, then the values are more reasonable and would correspond better to lymphoma. So when we look also analyze the lymphoma, we need to do the leakage correction, of course, as I say, but not only in lymphoma. It's very spectacular because there is a lot of leakage, but as I showed in glial tumor assessment, we also need the leakage correction because there will be some. So this is something extremely important when you look on your maps. Always check if there is a leakage correction. If not, the values can be sometimes aberrant. Sorry, not coffee break yet. Sorry for that. So finally, of course, we know that in tumor imaging, if we take just morphological markers, we have a lot of difficulties to do diagnosis. But if we take the conventional advanced markers, we can also be in difficulties. So we need to do more, and I think that having the multiple markers is something very important, and it can be really helpful and bring new information. Now the relation with PET, as we see, sometimes it's well correlated, sometimes it's also predicting what we will see on PET, sometimes it's overperforming. So now we are planning to do a multicentric study to see really in which case. Actually, this is the big question, because as I told you, we see a lot of patients, some of them we can do PET, but not all. So we should say, okay, in which cases, finally, these new markers could replace PET, and we can use them alone. And say, okay, this patient I can answer without PET, and in which cases it can have a real added value, but we also need PET. So this is something that we are going to analyze to allow more personalized medicine and more personalized follow-up of the tumors. Thank you for your attention.
Thank you so much for that wonderful presentation. Are there questions from the audience?
Yes, thank you very much. So I'm wondering if you can give us your impression on the performance of the methods after resection. So it is very susceptible to artifacts, the DSC method after resection. So especially when you have lesions growing around the resection, do you read it with any special care, or how do you go about?
Indeed, the problem is that there are a lot of artifacts. So the first thing that we are doing, especially in immediate post-op, we are doing also the classical perfusion, but also ISL that would be less sensitive to the artifacts. So this is one thing, and then I think what can be also helpful is the way you look on different maps and you think, okay, if there is something only in one, maybe it's due to the artifacts, but if the model is correct and there is the abnormalities in all the maps, so maybe it's really something that exists. So I think these are two ways to go. And also there are different, comparatively to the algorithm, there are different methods of artifact correction, so that can be also helpful to do the right diagnosis. But if you have really strong artifacts, then of course, first thing before you analyze the maps, look at the images. Because if there are too many artifacts, then you should say, okay, I will look on the maps, but I know that there are limits. So this is something that we cannot avoid doing. We still have to continue to look on the basic morphological imaging to understand what we are looking at.
There's a question here.
Have you had any current experience with DCE instead of DSC? Because it's T1 related instead of T2 star. So it would be less affected by subsibility artifacts.
Yes, it's a possibility. Well, for now, we are not using it much in clinical practice. The only use that we have for it is for brain blood barrier opening by ultrasound. So before chemotherapy admission, so this is something that we are doing, but this is probably to consider also. But for now, the post-processing also is sometimes complicated. We are not always trust completely the maps, but maybe this is something that Sarkar will work on. It doesn't work well.
That doesn't work. But
Let's go.
he's fast.
Thanks for the presentation. I would like to ask you, do you apply the RANO criteria when you report? That's the question. Because there are not many centers in the world that can do a FET MRI just like that. So do you apply the RANO criteria when you are reporting?
Well, this
And
is
then
a good question, but difficult one. So
just yes or no?
Yes and no, because because a lot of patients in our centers, they are included in clinical trials, and today for clinical trials you usually have one of the criteria that are RANO criteria, so we have to do it. But personally, do I like RANO criteria? No, because for especially complicated cases, usually you end up saying that by RANO criteria it is stable, but I really believe it's a progressive lesion.
Thanks. And my other question is, when the new guidelines regarding evaluation of stroke and the measurements of the volume were published, the American Heart Association, Microscope Association guidelines, basically they were based on volume measurements, which at the end were based on one software that was rapid. So I was always, if somebody else is applying those criteria, they could think, I'm well calculating the volumes here. That's one thing. But what I would like to ask you, the Sarkar markers which are presented here are interesting, and I really think that there is, as you showed, also something about that. But what if there are other vendors that will show the same thing, but they won't be called like that? Could it happen or no?
I cannot completely answer this question. I think not completely, because Sarkar did a patent on some of the maps. But no, honestly, the question is that you can find a lot of things and call it many names. But let's take an easy thing: the volumetry. Like you segment the brain with many methods, most of them based on free surfer. and you take any method, and the volumes are completely different. Why? We don't know the processing, so I think what is very important, there are two things. A validation, that we were talking a lot about it, and this is something that we are going continuously to work on comparatively to PET markers, because as you were saying, not everybody have PET, so we really need to see how perfusion can eventually replace it. This is the first thing, and also the experience, because while there are a lot of criteria, I also believe a lot in clinical experience for complicated cases. And so you really need, I believe, your own experience with the maps that you are working with, so then you can trust them and you can understand how they can help you.